Welcome back to Emergency Chaos, where we help you become the best ER nurse you can be. Today we're diving into acetylcysteine and acetaminophen overdose, when it's life-saving, when overdose turns deadly, and the exact protocol you need to know. Plus, I'll share key nursing tips to help you confidently handle these cases in the ER. By the end of this video, you won't know just the protocol, you're going to be ready to act fast when it matters most. So let's get into it. In the ER, you're going to see patients come in after an acetaminophen overdose, whether it's intentional or unintentional. Acetaminophen toxicity is the most common cause of acute liver failure in the US, and as an ER nurse, you need to know how it happens and how to respond. When a patient takes too much acetaminophen, their liver metabolizes it into a toxic byproduct. Normally, the body neutralizes this toxin by binding it to glutathione, an important antioxidant that helps detoxify harmful substances in the liver. But in overdose situations, in Tylenol overdose situations, glutathione stores become depleted, allowing this toxic metabolite to cause liver cell damage, and if left untreated, can cause liver failure. This is where acetylcysteine, or NAC, comes in. NAC helps restore glutathione reserves, allowing the liver to detoxify the harmful byproduct before it can cause irreversible damage. That's why acetylcysteine is the go-to antidote for acetaminophen toxicity. It gives the liver the protection it needs to recover. One of the most important things to remember with acetaminophen overdose is that symptoms don't always appear right away. Even if a patient feels completely fine, liver damage may already be happening. That's why we rely on lab results, especially the 4-hour acetaminophen level, to determine the treatment. When symptoms do appear, they often include right upper quadrant pain from liver inflammation, persistent nausea and vomiting, and early signs of liver dysfunction like jaundice and dark urine due to the bilirubin buildup. As liver function worsens, patients may develop confusion or mild drowsiness. Lab values are critical in assessing severity. AST and ALT typically begin to rise. INR may increase, signifying impaired clotting, and bilirubin levels start rising. The key takeaway: never assume a patient is fine just because they have no symptoms. If the labs indicate toxicity, treatment with NAC should begin immediately. If acetaminophen toxicity progresses untreated, it can lead to massive liver necrosis and multi-organ failure. Severe symptoms start to appear, jaundice becomes more pronounced, hepatic encephalopathy develops, leading to confusion, altered mental status, and so forth. Patients often experience severe right upper quadrant abdominal pain, persistent nausea and vomiting, signs of coagulopathy, such as unexplained bruising or bleeding. Hypoglycemia becomes a major concern as the liver loses its ability to regulate blood sugar, and metabolic acidosis, kidney injury, and multi-organ failure start to set in. Lab values reflect the severity of the condition. AST and ALT can skyrocket, INR becomes prolonged as clotting factors fail, and ammonia and lactate levels rise, signaling worsened liver dysfunction. If the liver failure is severe and untreated, death can occur due to multi-organ failure or massive bleeding. This is why early recognition and treatment with acetylcysteine are crucial to prevent a patient from reaching this stage. Timing is everything when treating acetaminophen overdose. NAC, acetylcysteine, is most effective when given within 8 hours, so early assessment is critical. But how do we decide who actually needs treatment? This is where this key graph comes in. This nomogram is a graph that helps determine the risk of liver toxicity after a single acute ingestion. It uses a patient's serum acetaminophen level at a specific time after ingestion, most accurately at the 4-hour mark from ingestion. This is because by 4 hours, acetaminophen has fully been absorbed and distributed, giving us the most reliable toxicity assessment. If a level is drawn too early, before the 4 hours, it can be misleading. In that case, it must be repeated at the 4-hour mark to ensure an accurate interpretation. If the 4-hour level is above the treatment line on the graph, NAC should be started immediately. When deciding whether to give NAC, we primarily rely on the graph, which compares the patient's acetaminophen level to the time since ingestion. If their level is above the treatment threshold, NAC should be started immediately. But what if we don't know when they took the overdose or took the acetaminophen? If the time of ingestion is unknown or delayed greater than those 8 hours, and there's any suspicion of acetaminophen toxicity, NAC should be started empirically while waiting for those results. It's better to begin treatment early than risk the liver damage. Additionally, if a patient is already showing signs of liver injury, such as elevated AST, ALT, jaundice, or encephalopathy, NAC is given regardless of the acetaminophen level. At this stage, the focus shifts from preventing toxicity to actively protecting the liver from further damage. And super quick, if you're finding this helpful and want to save time and energy with gaining confidence in the ER, check out our emergency nursing course and book. The course is packed with everything you need: foundational knowledge, charting fundamentals, quizzes, and practical tips to help you master the chaos of the ER. The book is going to be your go-to guide for essential ER knowledge, giving you key insights and strategies to handle real-world emergencies with confidence. You can also access the course by joining the channel as a member. Just click the join button. The links are going to be in the pinned comment and description below. When giving IV NAC, it's important to follow the proper infusion protocol to ensure safe and effective treatment. The standard regimen starts with 150 milligrams per kilogram loading dose over 60 minutes, followed by a 50 milligram per kilogram dose over 4 hours, and then a 100 milligram per kilogram dose over 16 hours. They're all going to be in D5W. For pediatric patients, dosing adjustments are necessary based on age and weight, so always verify with the pharmacist and follow your facility's approved protocol. One of the key concerns with IV NAC is infusions reactions. Mild flushing is common and doesn't require treatment. If the patient develops itchiness, hives, or so forth, Benadryl or diphenhydramine can be given. More severe reactions like angioedema, bronchospasms, or hypotension require stopping the infusion, treating with Benadryl, steroids, bronchodilators, and then restarting the acetylcysteine at a lower rate 1 hour later after the symptoms have already resolved. So from one hour from symptoms resolving. So most reactions are going to be very self-limited, and with proper management with the Benadryl, the steroids, bronchodilators, NAC can usually be restarted without complications. But always be safe. If the patient starts having any type of reaction, you need to stop it and let the provider know, and be ready to administer those medications that you would give for any patients having allergic reactions or going into anaphylaxis, right? But the best thing is stopping it and letting the provider know and being prepared to administer those medications. But in the countless times that I've administered this medication in the ER, I haven't once had any reactions yet, but just be aware that it is possible. And like with any medication, you need to be ready to act fast. Now, as an ER nurse, your role in managing acetaminophen overdose is critical, right? The first step is early management. If the patient presents within 1 hour of ingestion, activated charcoal may be given to limit absorption. Obtain a detailed history, including the time of ingestion, the amount taken, and any co-ingestions like alcohol or other medications. Monitor vital signs closely and assess for symptoms. Early signs include nausea, vomiting, and sweating, while late signs include jaundice, right upper quadrant pain, and confusion indicate liver damage. Labs are essential, with the key ones being the serum acetaminophen level at 4 hours post-ingestion, AST, ALT, INR, and bilirubin levels to assess liver function, and a BNP to monitor kidney function and blood glucose, as hypoglycemia is a serious risk in liver failure. Once NAC is started, monitor for infusion reactions. Mild flushing is common and doesn't require stopping it. But again, for any severe reaction or any reaction at all, just to be safe, just make sure you stop it, but be prepared to give medications like the diphenhydramine, steroids, and so forth. And then closely watch for signs of worsening liver failure, such as rising AST, ALT, INR going higher and higher, or changes in mental status. And if hypoglycemia develops, please check a point of care glucose and be ready to give dextrose. Also keep an eye on the urine output, as kidney injury is common. And then I want you to know that you're going to see acetylcysteine in other uses as well. So I want to talk about it briefly. So just beyond the acetaminophen overdose, NAC has other applications in liver protection. It's used in conditions like non-alcoholic fatty liver disease, chronic liver disease, and cirrhosis due to its ability to reduce the stress and inflammation on the liver, right? And it also helps protect the liver against medications that can lead to liver injury, right? So just know that you might see it in other things as well. And it's just because it has all these liver protective effects. And then just know that by staying on top of the early interventions, lab monitoring, and patient assessments, you can help prevent severe liver failure and improve outcomes for these patients. And that's why learning as a new ER nurse is the best thing that you can do, because you can stay ahead and plan ahead and advocate for your patients. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.